Ben bugün teşekkür ederim sana.
Now, today I'll be talking about treatment options in TRD. There are psychopharmacological approaches available, and I will try my best to cover them. My presentation is composed of 4 parts. First of all, I will talk about refractory depression and present you with a definition. The previous speakers also offered that, but I'd like to still offer you an explanation. And then I will talk about treatment of refractory depression, the agents that are available, the methods that are available, and then I will focus on pharmacotherapy options in TRD and new prospects and new studies that give us hope. Now, depression, when you look at it, all around the globe, it's one of the biggest healthcare problems. It's very problematic for the patients as well, because when a patient is diagnosed with cancer, they still fight against the disease. But when people are depressed, when people are diagnosed with depression, they don't necessarily find the strength to fight depression. In pure depression, it's even worse, and the progression is rather fast, because depression, by and large, is a manifestation of not being able to derive pleasure from life. And when you're depressed, your biggest weapon is taken away from you, and no other disease damages the capabilities more than depression. That's number one. And also, as the disease progresses, resistance is developed, and there are also financial and social factors, and there is a lot of burden on the patient, and sometimes it gets too difficult to carry that burden. It's one of the biggest killers in our world, depression is. That's why it's very important. 50-60% of depression is a good response rate. When you use first-line antidepressants, you get a good response generally by 50%, 60%. But there are so many factors that have an impact on the response. Some of these factors have to do with the physician, some with the patient. There are so many different factors that come into play. And also, there are pseudo-resistance occurrences. We diagnose patients with TRD, but we don't necessarily look into the details. And sometimes we overestimate TRD, and when the patient falls short of responding to the treatment, we put them in the TRD category. We don't look at the adherence, we don't look at the dosage or environmental factors, and we oversimplify things, and we also have a lot of pseudo-resistance in our practice, and we need to question the diagnosis of TRD in many of our patients. So how can we define a TRD? Is there a common definition? Well, actually, there is no one single definition. If 2 different antidepressants are used for a while sufficiently, if there is a lack of response, then the patient is deemed refractory. 2 different antidepressants that work on different mechanisms. That's the rule of thumb, or that was the case in the past, but now STAR-D study revealed some interesting results. Some of our convictions were upturned, and there's a lot of confusion. And the results of this study will have an impact on our treatment options and treatment preferences, albeit slowly. Now, let's take a look at the TRD study. It's quite a serious study. It's the most widespread study that has been conducted so far on depression. I will not go into details individually, but the patients are given an SSRI, and the response rate to that SSRI is about 28%, 30%. But suitable period, suitable dosage, that's key. 12 weeks at maximum dosage, 28%. We thought the response rate was 50% or 60%, but the TRD study revealed that not to be the case in terms of response. We have every reason to be suspicious. And then a different antidepressant from another group, we used to say, for the effect to come on. But in the second line, you see, when the switching is done, sertraline is given to the patients, and bupropion. Sertraline is from the same group, but there is no statistical difference in terms of response. It's about 20%. In augmentation, bupropion and buspirone is added, and the best efficacy is achieved through augmentation. Also, yet another striking finding is the thyroid preparate. In the third phase, augmentation is done, and when this T3 is added, the response is higher than the rest. And in terms of tolerability, the best profile is in the thyroid preparate, T3. And venlafaxine, mirtazapine is given to the patients on the third phase, and the response rate is 13%. So first of all, this gives us reason to question the response rates that we have come to believe. 60% has been slashed by half almost. And when you add TRD, we used to say that only 10 or 20% of the patients were TRD cases, but now we see that almost as high as 50 or 60% of our patients may exhibit TRD. Now, let's move on to the second section. In TRD, in refractory depression, what are the treatment approaches? There are 4 chapters here. Pharmacotherapy, I will go into details of that shortly. Psychotherapy is something that should be added to the treatment regimen. It's one of our strongest weapons. In one of the study arms, cognitive behavioral therapy, CBT, was added to the patients. And that arm exhibited the same efficacy as the second line patient. So it's quite efficacious, and it doesn't have any side effects. And the third chapter would be somatic treatments. One of them is also quite indispensable, maybe the first option, say for the, well, I will not go into details, but this is electroconvulsive therapy. And on many catatonic suicidal ideation or refractory patients, this is a very useful somatic treatment. Yet another method is transcranial magnetic stimulation. Dr. Adem is going to talk about the details of this shortly. And vagal nerve stimulation is another method for refractory patients. In the fourth main chapter, this is actually quite similar to somatic treatments, but it's a rather unique chronotherapeutic approaches. In the first couple of days or during the first couple of hours when you have a refractory patient, in order to make the patient feel better, this comes handy. Which one? Can you, when you can't sleep, what do we do? Sleep deprivation. This also causes, it kickstarts the effect. There is no chemistry involved, no electricity involved. no IV involved. So sleep deprivation can be used as a tool as well, and there are no side effects either. And the person, after the first day, feels better. But of course, it needs to be coupled with the right treatment, and also the efficacy over a long shown. Ketamine. When you give ketamine to the patient, it gives the patients a sense of well-being for the first 3 days, and it's almost on a with that. The sleep deprivation method is something that needs to be reckoned with. In clinical monitoring or follow-ups, we don't use this necessarily, but it still remains an important weapon. Sleep phase advance is another method. Light treatment is yet another option that can be utilized for TRD patients. So this was my brief introduction to TRD. Now let's move on to pharmacotherapy and look at what we use. There are so many different studies, obviously, and there are so many meta-analyses, large-scale studies, and there is a certain algorithm that has come into existence, but that algorithm does not necessarily work for every patient. It needs to be flexible, because in medicine there is no disease, there is the patient, as we know. That's why we always need to be patient-centric. The TRD study revealed some very shocking results and upturned some of our convictions, as I said previously, so we need to always focus on the patient. Now, pharmacotherapy options for TRD. In the first choice, we have, well, once TRD diagnosis has been made, and with the TRD study, two groups of antidepressants administered to the patient for a suitable period at suitable doses, 12 weeks, to achieve the maximum effect. If still there is no response to treatment, then, and the response is 50%, by the way, if there is no response, then the patient is diagnosed with TRD. So what are the next options once the diagnosis has been made? The conventional option is lithium, 0.4 to 1.0 plasma level. Of course, it has its ups and downs. These are indicated on the slide. One of the disadvantages is plasma monitoring that is needed, and a psychiatrist is needed to follow up on the patient. But we also need to rely on GPs a lot in the treatment of depression. I don't know if I'm mistaken, but in Turkey, most of the depressed patients go to the primary healthcare units, and 1/3 of them are not diagnosed, and 1/3 of the diagnosed do not get the right treatment. When you give lithium to the patient, specialists need to also be a part of the picture. It has poor tolerability at high doses, but still it remains the first choice, lithium treatment. The second option would be triiodothyronine, adding this to the treatment. TRD supports this agent, and this is even superior to lithium, says TRD, because it has a better tolerability. Compared to the other one, it's easier to monitorize, and in terms of titration, there are no strict restrictions. And the third option would be adding antipsychotics to the treatment. In contemporary bipolar depression, this has become a part of our daily practice. Olanzapine and fluoxetine can also be used in TRD, but it has a risk of weight gain, and it's expensive. But there are a lot of studies in this regard as well. Quetiapine, adding quetiapine, risperidone, aripiprazole. Studies have been conducted. They have good tolerability, but of course there are side effects that we need to be careful about. Again, as a first choice, we have, this is supported by STAR-D, bupropion augmentation, 400 milligrams per day. This is well tolerated, and this gives you the best level of success in the second phase. But in certain countries, it is still not licensed for depression. That's the problem. Another option, SSRI or venlafaxine with mianserin or mirtazapine. This is recommended highly, and actually this is our first choice in our clinical practice. And we turn to these two weapons a lot. But of course there's a serotonin syndrome risk, that's why we need to follow up on the patients very closely. A second group of drugs, lamotrigine, adding lamotrigine to the treatment. It can be beneficial at a low dose as well, but you can titrate it up to 200 milligrams. It has good advantages, it's well researched, and it's one of the best researched, especially for bipolar depression. We have robust data on this agent, but titration is slow, and there is a risk of rashes on the patient. That's quite serious. And this restricts the use. Adding pindolol to the treatment, this is also well researched, well tolerated, but in certain publications, efficacy is not really shown to the fullest extent. During the first phase of treatment, to get a fast response, we can use pindolol, and it's also well tolerated, as I said. Adding buspirone to SSRI, this is supported by STAR-D up to 60 milligrams per day, and certain good results have been achieved, so it can be a second option. Venlafaxine, more than 200 milligrams per day. This is also good, has a good tolerability, and to be careful. In addition to these two options, there are other medications, and randomized controlled trials were made for the first group, especially STAR-D, and there are this third group, the other reported treatments, they have scant data. That's why we need to be careful about them. So I will not go into details, but you may as well take a look. Amantadine, carbargolene, now in this group, what is striking is this. Maybe combining MAOI and TCA. This is a long history of successful use, but we need to monitor the patients well. Modafinil, it hasn't been researched well, but its efficacy has been shown. Tricyclic SSRI combinations, high dose, was formerly widely used, but still, from time to time, we use these combinations as well. Again, high-dose venlafaxine or IV clomipramine is another option. So, how about new perspectives, new hopes in treatment of TRD? In pharmacotherapy, glutamatergic system has come to the foreground. This was covered by Professor Erol yesterday. Ketamine, an NMDA receptor antagonist, within a couple of hours its effect comes on, and it's worth studying. Magnesium balance, redressing the magnesium balance. This was studied before, but it has an impact on the synaptic formulations in the brain, and it may be a new target for us for future studies. Anti-glucocorticoid treatment may offer us hope. Professor Ferrier talked about this. Metirapone. There's a study which is quite substantial, and it offers us hope. It's very promising. Also, neuroinflammation and neuroprogression. There's a study as well, actually a couple of studies. There are so many publications about these, and we have also had some publications in this regard. From antioxidants to kinase inhibitors. There are so many different studies. There are 10 subtitles of this, and Professor Leonard works on these. And there are new target medications that may have antidepressant values for us. Through enzyme activations, new targets can be achieved. In this group, it's an open field, so to speak, and it offers us hope for the future. Others, I will not go into details, but there is magnetic seizure therapy, deep brain stimulation, transcranial direct current stimulation, and also there is ablative surgery that may offer us hope in the future. This is all I have to say. Thank you for your attention.
Evet.